Hello, everyone. The webinar will start in about 8 minutes. Audio check, 1, 2, 3. Can everyone hear me? Hello, everyone. We're going to start the webinar in 2 minutes. Can someone please type in the chat box that you can hear me? I have to switch from headset to call in on the remote phone. Hello, everyone. I'm hoping that everyone can hear me. I apparently had a little bit of technical difficulties. What's a day without a technical issue? If you cannot hear me or see my screen, please type me a message or raise your hand in the GoToWebinar side panel. Again, hopefully everything's working well. Good afternoon, everyone, and welcome to PointRight's Patient-Driven Payment Model Training Series. Today is the second session, and the focus of the topic is on non-therapy ancillary, understanding the facts. My name is Paola DiNatale. And before I get started, there's a few housekeeping details that I'd like to go over with you. This session is being recorded. Also, the link to the recording will be made available on our website, the same site that you have registered for these sessions. The phone lines are muted. There is the chat box on if you expand the side panel of the GoToWebinar, there is the chat box where you can enter and type your questions. If there is time at the top of the hour, since there's quite a bit of information to go over, I will answer questions. If not, don't worry, I will follow it up via email, but hopefully there will be time. There's also a PDF version of the presentation that is also is made available through the side panel that you can download for your use. And lastly, the session is approved for CE credits. Information on how to obtain the CE for nursing and also for the NHAs, I will be explaining that at the ending of the session. So let's get started. Close off the side panel. And again, I'm hoping that I am live and everyone that called in can hear me. If not, I truly apologize. This series of education sessions is intended to provide insight and information on the new Medicare reimbursement methodology that CMS rolled out several months ago, which is going to be replacing the current Medicare PPS or grouper classification system. And that's going to go into effect October of 2019, which is going to impact the fiscal year 2020. The information that I am presenting today is as current and as updated as what was made available to me as of today when I last checked this morning. The learning objectives for this session is to provide an overview of non-therapy ancillary case mix component and also to identify and discuss the top 50 conditions or services that are most costly, especially those top 3, but basically to review and go over those 50 conditions, which are kind of like the drivers for NTA, taking a focus on the MDS dataset items, along with utilizing, the ICD-10 CM codes for determining the resident's NTA comorbidity and extensive services score. And also talk a little bit about some strategies for you all to get ready as you prepare in developing a strategic plan, and starting early on. That way it can facilitate a work plan to support your NTA communications and documentation. Before I dive right into today's session, I do want to do a brief recap. Last month was our first session of this PDPM series, and the topic was on PDPM the basics, which was presented by my colleague Pam Kaiser. And as you can see, I do have a link for you to add, for those of you that were unable to register for the live presentation, but at least we do have a link on our homepage where you can access the webinar. But having said that, I do want to provide a brief recap before I entail and start talking about that whole NTA component. First of all, the PDPM, as I mentioned, is going to replace the current fee-for-service Medicare PPS reimbursement classification system. PDPM has 6 components, and each component is independently determined by specific drivers. Each resident would be classified into a resident group for each of the case mix adjusted components, actually for 5 out of the 6. The non-nursing, that's basically like environment, room and board, and so forth. It's going to, PDPM removes therapy minutes as the basis for therapy payment. It takes into consideration the resident characteristics that are derived from diagnoses, conditions, treatments, etc. And there are, like I mentioned, 6 components, and these are physical therapy, occupational therapy, speech language pathology, non-therapy ancillary, which is going to be my focus of the presentation today, the non-nursing case mix, and the nursing case mix. This is, PDPM is going to be a budget neutral per diem payment. It is, there's going to be an adjusted variable factor, which impacts physical therapy, occupational therapy, and the non-therapy ancillary, which I will also explain it further into a little bit more detail relative to NTA. But basically what that adjustment and that variable factor is going to do is going to identify from the point that the resident is admitted in your facility for PT, OT, and NTA, where in their stay the payment, there's going to be an adjustment in the per diem rate. There's also fewer MDS assessments to complete compared to the Medicare PPS. These are down to 2. These 2 assessments are now your 5-day Medicare MDS assessment, which also includes the 3-day grace day and the discharge assessment. That discharge assessment, the Medicare discharge assessment rather, is where the therapy minutes are going to be captured on Section O. There's also voluntary and optional, as CMS has identified, additional assessment if you choose to complete it, and that's called the Interim payment assessment, which I will also explain a little bit further later on. And this has specific criteria. Again, it is optional and voluntary, but there are specific criteria that must be met that are identified by CMS. There is, let me see, PDPM would better align with current direction of the post-acute care reform and standardization efforts supported by the IMPACT Act. And there's be spending some time talking about the ICD-10-CM coding and the MDS data set items. And as you can see, there is the link to access the PDPM, the first series, and I would hope that you do so. Even if you use it as an additional educational session for some of your team members, I do believe that the more we hear about this, the more that we can get it embedded in our brain, wrap our heads around it, and kind of digest this information, because it is somewhat overwhelming. Moving on, this is an orbital view of the case mix components. As you can see, it's the resident rate is in the center, and that kind of like that circular view is that each one of the components is actually going to be adding and providing that calculation, if you will, identify that the resident rate or the per diem rate based on those specific drivers and resident characteristics. This is another view of the payment drivers as it relates to the 5 components. And down below, you can, you can see that the variable per diem adjustment schedule impacts physical therapy, occupational therapy, and the non-therapy ancillary. Now let me go right into the non-therapy ancillaries. The non-therapy ancillary is a separate case mix adjusted component, and this kind of allocates system resources as it relates to the medically complex beneficiaries. CMS noted in their proposed ruling that certain factors and variables on the non-therapy ancillary, and there was quite a bit of comments from the commentary and the reviewers. And with the final rule, CMS did indicate that if they're considering the comments received for the reasons discussed in the proposed rule and in the final rule, CMS was finalizing the NTA component of the PDM and the proposed classification methodology. So from the proposed to the final rule, there was really not much that was changed as it was identified early on in the proposed rule and as it's stated in the final rule. NTA is also establishing a separate case mix adjusted component specifically for the NTA services. and these specifically target the resources that are going to be utilized for these medically complex residents, and also to ensure that there's an accuracy of the services through those the MDS data set coding. There are 50 conditions that are considered as the drivers, and those conditions and extensive services that were identified through a retrospective study that CMS conducted, that they were identified as the most costly. There were 3 top conditions and services with the highest points: HIV/AIDS with the highest point of 8, then followed by parenteral feeding, which level high, and special treatments programs, IV med post-admit code, which was the 3rd on the list, with also the highest points. The CMS noted that the current SNF PPS uses claims reporting mechanism as the basis for the temporary AIDS add-on on payment, which exists under the rug for. The HIV and AIDS is not a component that can be captured on the MDS. This is one out of the 50 conditions, what I would show in a later slide when I show you the view of all of the conditions, is the only one that gets identified through the SNF claim. And that specific code is code B20, and it's one of the codes from the ICD-10-CM classification system. And this code is going to address reporting this specific diagnoses, and it's also going to utilize the existing claims reporting. So from the facility level, you're not going to need to utilize it to do anything differently. If you happen to be a facility that have residents with this particular condition, you're going to follow suit the same process in identifying this specific diagnosis by coding it in your SNF claim, which is the manual entry into your UB04, and by entering the code B20. The MDS sections that are kind of like the drivers in those conditions are Section H, bowel and bladder; Section K, swallowing and nutritional status; Section M, skin conditions; Section O, special treatments and procedures; Section I, active diagnoses. That's the section where you're going to check off those particular diagnoses. And Section and the Section I-8000, the additional active diagnosis, which is where you open text boxes that you have to manually enter the specific ICD-10 diagnosis codes. Their CMS did release a crosswalk and a mapping. It is kind of like a huge file, but I do encourage you, if at all possible, to download it and start perusing through the file and taking a closer look at those specific mapped diagnoses as it relates to specifically to these 50 conditions. There's also the link, if you have not had the opportunity to download it, for you to go ahead and download it onto your desktop or onto a document. This will also be good to include members of your interdisciplinary team to let them be aware of what are the changes, especially since we're looking at every single one of these 5 out of the 6 PDPM components is going to be providing an independent type of a case mix classification per se, and adding to that per diem rate. So you want to ensure that you're capturing all of those appropriate diagnoses. I wanted to also take a few minutes to go over a little bit about this ICD-10-CM coding and what is it exactly. It's not anything that is foreign to us. It replaced the ICD-9 version a few years back, and we had to go through that transition of adapting this. But basically, this stands for International Classification of Diseases. That's the ICD. The number 10th is for the 10th revision, and the CM is the clinical modification. And basically, these are guidelines that provide morbidity classifications, and This particular guideline was just revised for the 2018 and September 2019 period, and it has extensive explanation there for the HIV and AIDS, the B20, and also some of the about the Z codes. That's why I would encourage you to kind of like download that guideline as well, and I have that available in the reference list at the ending of the presentation. The guidelines were approved by the American Hospital Association, AHIMA, the American Health Information Management Association, and also by CMS. The ICD-10 or alphabetic index in a tabular list, and these codes are used for reporting purposes. And there is, it really became very extensive compared to, for those of us that remember the ICD-9 version. And honestly there, while we were adjusting to the ICD-10, I know that we looked at some of those and we thought, really, some of these were kind of sounded a little bit ridiculous, and we often thought, like, when are we ever going to use these? But it's very, very extensive. And the codes identify acute and chronic conditions, conditions that are integral part of a disease process, signs and symptoms, diagnostic services, therapeutic services, and also any kind of impending or threatening conditions. The level of detail coding, and here I have kind of like a link for the guidelines that I just mentioned to you. Obviously, in order to code a specific diagnosis, it needs to be a diagnosis that is clearly identified and documented, and that documentation has to be initiated by the patient or the residence provider. That provider is the physician or other qualified healthcare practitioner that is legally accountable for establishing the patient diagnosis. None of this has changed. This is all, I'm just doing kind of like a bit of a refresh, only because of the NTA is so heavily driven by the accurate ICD-10 coding, establishing those ICD-10 codes, and also MDS dataset items. This is the portion. I couldn't fit it in the entire sheet on one slide, but this is a view of what those conditions and extensive services are. As you can see, the top three, HIV/AIDS, parenteral IV feeding, which is your level high, and then special treatments programs, IV medication, post-admit code, and that's the third one on the list. So as you look at these, you can see the column to the far right where the points are allocated. There's a total of about 83 points based on all of these conditions. Let me backtrack again if I can. Based on the entire list, based on the 50 conditions, these are the top three, and then you have the subsequent two, which is a 4. There's two that are 3, several that are 2, and then the remainings are all 1 score point. And I'll explain later what all this means as it relates to NTA. This is an example of where the source of the HIV and AIDS coding is going to be required to be entered, and that's going to be in your SNF claim, which means that the source document is not going to be the MDS. So you're going to follow whatever system you currently have in place through your software billing system. It's going to have to be manually entered, as I said, into your UB04. And according to the final ruling, it's on your first SNF billing. And then that will yield 8 points towards NTA. Obviously, you want to ensure that this is an appropriate diagnosis code that falls under the B20 coding. This is another example. As you can see, there's the source document for several of these is specific MDS data set items, and the non-therapy ancillary, the 50 conditions that specifically let you know which are those specific MDS item sets outside of the section I-8000. This is the example where you would enter those ICD-10 codes. And again, I would encourage you and advise you to download the ICD-10 crosswalk and mapping the CMS release so you can start identifying what are some of those specific conditions and diagnoses that you're currently seeing in your building. Also, utilize this list of that CMS has provided specific to NTA, but also to help you identify some competencies. For example, if let me go to the next one. This is a similar list now identifying more of those 50 conditions, but here specifically with suctioning. If this is an area that, and this is one of the conditions that would be coded on section 00100 while a resident, and basically what you want to do is just ensure that there's competencies, especially if the procedure that is being done by your nursing staff or by, if you have an in-house respiratory therapist, ensure those competencies, evaluate those assessment skills, and again, ensure that this is all accurate, that there's a mechanism to be able to capture this so that you can appropriately get credit and be incorporated into your reimbursement and then to that per diem. Obviously, you do not want to be losing any money on this by any means. The NTA scoring, as I mentioned, there's 83 points in total that can possibly be obtained when you add each one of the points allocated to the 50 conditions. Obviously, through retrospective study that was done by CMS and through Acumen provided a technical report on this, and they were very, very detailed relative to the specific component. And through that retrospective study, it was identified that obviously you're not going to find a resident with 83 points, that is going to have check off every single one of those conditions. That is going to be very, very unlikely. However, they did find not many, but there were several situations where that NTA score range went above 32, was up to 32 points. So CMS defined the NTA score range to identify 6 case mix groupings, as you can see on this slide here. The points start from a range from 0 to 12 plus. And typically, the average range was about 11 total score points, which would yield an NTA case mix index of 2.53. So what happens to all of these points? And since each PDPM component independently provides a rate, if you will, how does all this play out? I know that we're still trying to really figure it all out, even though that CMS has provided us with these visual tabular graphics. It's still kind of like, what does the end result look like? And that's still I guess for us to kind of like a wait and see mode for right now. But in the meantime, you can see that PT, OT, and the NTA has a base rate times the case mix index, as I have showed you on that prior slide. And the 3 of these have an additional calculation that gets factored into these 3, and that's the adjustment factor, which I will explain in my next slide. All of these, then, you add these up then to come up with what is going to be that resident rate or that per diem rate that is going to be the final, if you will, replacing the RUG group or classification. So what about this variable per diem adjustment? Um, we hear it in both ways, variable per diem or adjustment factor. Actually, they're one and the same. They're used interchangeably. They both mean the same thing. And this accounts for changes in cost, and basically it looks at where in the point where the resident is admitted in your facility, from the point that they're admitted, how many days within that first 100 days, obviously we're talking about, the Medicare fee-for-service, the 100 days, where during that stay, and for PT and OT, there is an adjustment factor which takes place after day 21. So for PT and OT, there's a payment rate specific for day 1 to 20, and then from day 21 to day 100, the rate basically drops about 2% every 7 days from day 21 to 100. How it relates, this adjustment factor, with the non-therapy ancillary, let me go to that slide. Basically, the first 3 days, the rate is set basically at 100%, and that adjustment factor is 3.00. After the third day, that adjustment factor from days 4 through 100, it kind of becomes constant. It drops 70% or 2/3, and it drops down to 1.00. And why is this happening is because during that research, they felt that the most costlier, or where the costly services get captured for those expensive services and treatment, is in the first few days, and actually the first 3 days of initiation of services for the beneficiary. So moving along to the MDS assessments. The MDS assessments I have mentioned, there are less that are going to be completed and done. It's going to, there's only 2 on the list. Based on the PDPM schedule, there is the 5-day MDS assessment, which also has included the 3 grace days, so you have from day 1 to 8, and also the PPS discharge assessment, which is required. So these are the only 2 that are required. Now, their OBRA assessments are not going away. Those are still going to be required for those long-stay residents, or if you have a resident that is going to be staying there longer than your 14 days, then obviously you're going to need to do the admission assessment, followed by the quarterly assessment if they're there beyond the 90 days during the 100 days of their skill level of services. You also are going to be required the over significant change, the significant corrections, the discharge, the entry, and death in the facility tracking form. So those are not going away. Now, there is that additional assessment, which I mentioned during the brief recap, that is considered an optional and voluntary, and that's the interim payment assessment. This slide just shows you more of a explaining it as far as the 5-day schedule PPS assessment, and the reference date is from days 1 to 8. And what it covers all Part A days until the discharge, unless an IPA is completed, and there's certain criteria for the IPA, which I will explain. Then the PPS discharge assessment, which that's going to equal to the end date of the most recent Medicare stay, which is going to be captured on A2400C. The interim payment assessment, that you have about 14 days. The AOD cannot be set later than the 14 days. And it has to be a change in the first-year classifications in order to be considered to do an IPA. So let's explain this a little bit further. I mentioned it is optional and voluntary. So I guess CMS was kind enough to have us that, but also bear in mind that they're going to be watching how we are going to be utilizing this assessment, how often are these assessments going to be utilized, because obviously it's going to, it may change the payment system. So obviously they're going to be watching it. And I'm not a betting woman per se, but I would also speculate to say that this may be a factor that we eventually will probably be seeing reporting in the PEPR reports. So I'm just saying, but putting it out there that just speculating. Hopefully not, but it is something that they're watching. So you're still going to be using the same MDN tool, the 5-day assessment, except you have 14 days now to set your ARD and complete it. There's 2 criteria that must be met, and this is going to be verbatim, and please bear with me while I read this. This is pulled right from the final rule. And the first criteria is, if you're going to be completing an IPA, is there has to be a change in the residence classification in at least one of the first tier. Those first tiers are the PTOT, speech language pathology, the nursing component, and the non-therapy ancillary component. So those are the 5. Okay, so there has to be a change in one of those to even consider it. And that change has to be so that the resident would be classified into a component that differs from the 5-day assessment. And the change results in a change in payment, which would be that per diem rate, either in one particular payment component or it's going to impact the overall payment for the resident. So again, the criteria is to consider that if there's going to be a change in the first tier, one of these 5, and it's going to have to be so that it's going to be changing what that payment rate, that per diem rate that 5-day assessment has already identified. There's going to be a change in that. Also, the second criteria is that the change are such that the resident would not be expected to return to his or her original clinical status within a 14-day period. So what does this mean for the facility? What it means is that although it is optional and voluntary and it's leaving it up to the discretion of each of the facilities, each of the provider, I would highly encourage you to start talking about this, to pull up the final rule. There's more explanations about this in the final rule. And even though it's a large document, download it and then click Control F and do a search engine there and search for these criteria for IPA, and you'll see it. And it's easily, it's an easy read, and it really explains it into detail how to further explore those opportunities at the facility if you're going to be considering engaging and doing an IPA. Obviously, I personally am looking at this, if it was my facility, as an interdisciplinary approach involvement and taking everyone input, obviously, because you're looking at those critical 5 components, where are the changes, and it's going to involve interdisciplinary team that are involved in completing those specific sections of the assessment, in pulling them together and talking about what are going to be some of the, how are we going to meet these criteria? What are going to be some of these communications that we're going to have? Is it going to be in our morning huddle, in our meetings that we have, in discussing our Medicare PPS residents? Whatever forum that you have currently, evaluate that. Is it working for you? Are there gaps in that? Is there an area for an opportunity to improve on that? And this is where you can engage in those discussions moving forward and determining how you're going to establish the IPA. You're already good to go in doing the 5-day Medicare assessment. We've already been ingrained in doing that. It's just that you have the additional, now you have embedded that 8-day component to set your ARD. Now, I want to talk a little bit about that interrupted stay policy. Again, there are 2 specific scenarios, and CMS is very specific and detailed with these scenarios in the final rule. I would encourage you to read these, so if there's any interruption in this stay, you'll know if it's going to impact or affect where it's going to be resetting or where you will have to restart, per se, another assessment to get them back on track with the PDPM component. So the interrupted stay is consistent with regulations from the post-acute care settings. Now, there are 2 scenarios, and I'm going to read these as well. If a resident is discharged from your SNF and returns to the same SNF by 12 midnight by the end of the third day, okay, that's 3 days, the resident stay is considered a continuation of the previous stay, right? So it's not going to reset or restart the that PDPM program, for lack of a better word. Okay, so this is one scenario. So if the resident goes back out to, let's say, the hospital and comes back in within, that by 12 midnight within that third day, then it's not going to restart that PDPM payment schedule. The second scenario is if a resident is going longer than 3 days. Let's say it's admitted to another SNF. The readmission is a new stay in which the resident then will receive a new 5-day assessment upon admission, and the variable per diem adjustment schedule for the resident would then reset to day 1. So again, the first scenario is not going to reset, let's say, that adjustment factor for PT, OT, and the NTA. But for this scenario, the second scenario, where clearly, it makes sense, you're going to have to complete a new 5-day assessment. That's basically resetting kind of like the clock, if you will, and resetting the PDPM schedule. The interruption window is the 3-day period. And that's kind of like that operative word. And again, I would encourage you, if this is an area, to also establish a better understanding, and that would be something that I would encourage you to kind of engage with your interdisciplinary team and other members of your team to basically have a thorough understanding of the interrupted state policy and how that is going, especially if you have residents that have a frequency that are kind of like your outliers, that have a frequency of going back out to the hospital. You want to really identify and do some root cause analysis of why is that happening and what are those contributing diagnoses. Now, the interrupted state policy also states that the readmission can be from community, from a hospital, or from another facility, and it is based solely on the length of time between when the resident was discharged from the SNF and the days until subsequent readmission to a SNF or a different SNF. Now, let's talk a little bit about operational strategies. Now, these are where having an understanding specifically to non-therapy and ancillaries is what is the current state. I'm going to pause here for a minute. Hold on. Let me make sure. Check. I see a hand raised. I don't know. Okay, we're good. Sorry about that. I just got a little prompt on my phone. Again, I truly apologize for these technical issues today. So the current state operational strategies, this provides you an opportunity specific to NTA, but also looking at the global PDPM process to really take a closer look at your current state of affairs as it relates to the foundation of the minimum data set, the current workflow process communications among your interdisciplinary team. So bearing in mind that the minimum data set is bears the foundation for the care planning process, that it kind of drives the care planning, thus to mitigate any kind of untoward events and to ensure that you have appropriate interventions there to mitigate any kind of negative outcomes and provide that quality of care and optimize quality of life, all of that goodness that you will provide to capture that. Also, the minimum data set is the current source document for the quality measures, which drives the 5-star outcomes and also the quality reporting programs, and then it gets reported for the consumers through the public forums such as the Nursing Home Compare. So, and also the MDS is the current PPS reimbursement is the driver basically for the current PPS reimbursement system, which is we have in place right now. Now, most providers have several MDS accuracy systems through their EHR. If you're a client of ours and you're utilizing the data integrity audit, that's another process. And whatever system you're using, or you're using a combination of systems, I would encourage you, if you get any kind of alerts or prompts for any type of coding inaccuracies, coding discrepancies, I would encourage you not to take those lightly, to really take those seriously. And since the PDPM component is going to be driven very heavily by the documentation on the MDS, by the codings on the MDS dataset items, and by ICD-10 codings, and specifically, and some which are on that active diagnoses list that were being manually entered. So how can you go about getting ready? Getting ready is assessing and evaluating your current MDS assessment process. I believe that the burden does not lie solely on one person. The MDS coordinator, the one who is coordinating this process, is an interdisciplinary approach. As a former DON and former nursing home administrator, I relied on that collective approach of an interdisciplinary team, since everybody has their hands, everybody is involved in assessing, observing, monitoring the resident, and adding certain details into this assessment, into this instrument that then trickles into those related quality metrics from the provider side. So review that workflow process. Look at, are there any gaps in the documentation, in the communication rather? Are there gaps in, you find right now that there's insufficient documentation, that's an area of weakness of supportive documentation? I'm going to tell you right now that daily skill documentation, that's not going away. And I know that we all have electronic health records right now, so that's still going to be a critical component as it relates to the Medicare fee-for-service. Even relative to PDPM, you're still going to be documenting to support those, especially if they have a stage 4 pressure ulcer, you're going to be documenting on that. You're going to be documenting on the treatment and whether the pressure ulcer is getting better or not, or whether there's changes to the treatments and how or if the residents receive suctioning, you're going to be documenting on that as well. Section GG is going to be very key and important. This is going to be measuring functional areas. There were some changes this past October, and again, there may be potential changes come October when PDPM is going to be effective at October 2019. I would also expect some additional changes to the MDS, but we're used to that. We're accustomed to that. That's been happening quite a bit through these past several years, where we roll with the punches. We know that CMS come October is going to have some additional changes that we're going to need to be prepared for, and hopefully they'll give us advance notice so we can better prepare for that. Therapy documentation with the days and minutes. What is your current process right now? How you're capturing that? Or there are gaps in that? Or you finding that also can be an area of improvement, especially since that's going to be specifically captured in the discharge assessment in Section O. What are the mechanisms and processes that you're going to have in place specifically for PDPM? Also, as I mentioned, and I spoke in great detail about this, identifying any kind of changes in condition relative to utilizing and doing an additional assessment, such as that interim payment assessment. Review what are going to be the criteria, and that you're all very solid in that process as a collective team. Also planning for MDS assessments and modification. Now they get ready and set. Communication, communication, communication. This is going to be very important, especially specifically to NTA, into those 10 conditions. You already know that the HIV/AIDS, the source document is going to be the SNF claim. Think about what is your current process right now. Is that working? How are you communicating that to your billing software? How are you communicating that if you're not the one currently actively entering that into the UB04, into your SNF claim, who is? And involve that person into the communication so that they're aware and knowledgeable about what is happening with these current changes and how it impacts that specific criteria, especially if there's a specific resident that is being admitted, and you have to incorporate that B20 code into the SNF claim. That communication is very key with your ID interdisciplinary team. Formulate a cohesive approach. Again, hopefully you all have a solid working relationship with every single member of your interdisciplinary team, but if not, where are the gaps? Start identifying that. You have time. We still have months, but don't wait till the very end. We have these sessions where we are helping you to strategize and start thinking about what are some of those operational strategies that you need to incorporate if you do not have them in place, or if you do, wonderful, I applaud your efforts, but if they're there but they're not working so well, what do you need to do? Assess, evaluate, pull the team together to educate and get their feedback and input how to make it a more cohesive approach and that works well. Also utilize resources. I mentioned a few. I have a reference list at the end of the slide. Download those resources. Download the final version of the final ruling of the PDPM, and really, that's not a document just for a few key members of a facility to start digesting. This is something that I mentioned before as a former nursing home administrator and former DON. If I was currently in your shoes, I would pull certain segments of that and start talking about that and start educating my team, and also pulling in the nursing assistants, especially if they're going to be involved in adding that insight in Section G, and you want to make sure that you're capturing all of the appropriate information and assist them in communicating to you and to the interdisciplinary team what is their observation and what are those changes, because obviously you're not going to be able to be at the bedside 24/7 next to the resident. Build and strengthen relationships with your referring hospitals. If you happen to be a center with a case manager, that is that link between your hospital and your facility. That's great if you have that position in place. That's another position that is a key member of your interdisciplinary team. I would highly involve them into this education piece and have them be aware of what are those pieces of information that you need from a hospital from the get-go. Obviously, having the mindset that PDPM is going to be solely driven by the hospital claims and those diagnoses, the answer is no, is going to be the MDS. Yes, there's going to be diagnoses and those treatment modalities for these residents that are coming in your building, and those are those diagnoses and conditions that you're going to be capturing on the MDS. But PDPM is going to be, the drivers are going to be specifically what is going to be captured from the MDS for those critical tiers, those 5 components in PDPM. I already mentioned about using the resources to assist you. Download the crosswalk for the ICD-10 coding, and also educational training sessions. We have several down the road. Register for these sessions. And also, we're going to be providing the recordings on our website. Download those recordings. You can pause them. Use them during your lunch and learn session. Even if you have certain segments, pull in a team, review it, have a discussion around our trainings, and even if you pull up the operational strategies, because I know my colleague had them for PDPM, the basics, and I have these specific to the NTA. Use these to help you better strategize how to move forward and to be ready. And yes, get ready, set, go, to be in that element where you are good to go. Foremost and more importantly, if I can leave you with a word of wisdom, is to really establish an attitude of an all-inclusive facility involvement. It cannot be done by one person. It cannot be the administrator, cannot be the DON, the therapy department. It's everyone. It's all hands on deck. Everyone involved, but everyone also needs to have a knowledge. So share that knowledge, bring everyone involved into the mix, into the group, so everyone is speaking that same language. And trust me, as one that speaks 3 languages fluently, sometimes with my brain, so it's really important that everybody is speaking that PDPM language, so you're capturing those components and that in an accurate fashion. This is another visual that I wanted to leave you with. It's being in a part of the healthcare setting for over 40 plus years as a nurse. We've been challenged with many obstacles thrown our way, not necessarily obstacles per se, but more challenges. For those of you that are not familiar with this picture, I'm sure it's familiar to some of you, is the angel oak tree from Charleston, South Carolina. I love this visual. I pull it up very often, and it can tell a story for whoever views it. However, it represents strength, endurance, resilience, essence, which all provides kind of like a foundational core to succeed amidst all challenges that cross its path. It can have different meanings to how you perceive it. The core, the trunk of the tree, can be the resident rate, the per-diem rate. The branches, and you can see some of the branches are actually on the floor, on the ground of this tree, holding this tree, but it has never broken off. This is what's so amazing to me about the strength and the resilience of this ancient tree. But it can be the visual for PDPM. It can be the visual for the resident. And the limbs of this tree can be the interdisciplinary team pulling together. It can be the facility as the center core and the inner workings of the operations of the facility establishing a cohesive approach. So I'm leaving you with this. You may think it's corny, but I hope it helps you to endure these challenges that are forthcoming. This is the reference list for your use. Is the crosswalk, the guidelines, the ICD-10 guidelines, and you can click right on these links to download the final rule. And also that technical report, which I pulled quite a bit of knowledge from as I was preparing for this NTA preparation. Please save the date. The next presentation is session 3. That'll be on November 27th. And that is the ICD-10 code and the drivers of PDPM. You have my name and contact information, and I really am hopeful that you heard me today and that it wasn't all this in vain. I hope all worked well with the audio and sharing my screen. The more important thing is getting your CEUs. There will be an online evaluation, SurveyMonkey, that will be emailed to you. If not, please copy this link to your web browser, and it will take you directly to today's presentation where you have to kind of complete the Survey Monkey and rate this presentation. You have up to Friday of October the 26th to complete it, to be able then to download your CE. Each attendee has to complete their own individual survey. So if you had many of you that were in the room and you only called in through one particular line, then please forward the link to your friend so they can go ahead and download their individual CEs. The nursing certificate you'll be able to download as soon as you complete the Survey Monkey. However, the NHA download what happens is, for a licensed nursing home administrator, you will have to enter your NAB ID, and that is different than your license, your NHA licensure. Myself, I had to register in the NAB website, and that's the www.nabweb.org. You do not have to pay for this, but since I believe either within April and June, NAB made it more of a requirement that licensed administrators would need to, if you wanted to get credit for a specific session, we would have to provide our NAB ID number, and that ID number starts with the letter R, followed by either 5 or 6 numerical numbers. So again, if you're a licensed nursing home administrator, I would encourage to please, if you haven't joined yet, to register. Now, what happens then is the PointRight, when you enter your NAB registry number, PointRight is going to go ahead and send that number to NAB, and then give them about a couple weeks, about 3 weeks or so, and then you're going to see this session is going to be in the listing, and then you can print that for your copy. So you know, you can start adding up how many CEUs you have available. Okay, I have about 2 minutes. Let me see if the chat box, there are any questions. I don't see any right now. If anybody's hand is raised, no. Okay, well, I don't see any questions, but these questions are recorded in our training, so I will certainly follow up if there's any questions. Again, I will leave this slide up for the next minute or so, and thank you so much for joining me during this presentation. Have a great afternoon, everyone.